The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Welcome everyone to another episode of the Success in Practice podcast. Today I'm joined by Charles Beck. He prefers to call him Charlie. So Charlie is a US-trained DO, a Doctor of Osteopathy. He went to Osteopathic Medical School in Pikeville, Kentucky, starting in 1999 and graduating in 2004. After completing an additional undergraduate fellowship year, which is an added year to learn more about osteopathic manipulation, he did his internship and residency in Indianapolis and finished in 2007. He's a board certified osteopath in osteopathic medicine that specializes in manual treatment of the body called neuromusculoskeletal medicine, otherwise known as osteopathic manipulative medicine. He has a certificate of proficiency in cranial osteopathy. He is a fellow in the American Academy of Osteopathy and a fellow of the American Academy of Ozone Therapy. He is also a certified thermographer. He has a passion for teaching and helping others learn more about how to treat the body and achieve optimum health. His teaching is based on principles and anatomy, staying true to Dr. Steele's approach. He encourages students on how to think with the feedback from their hands and problem solve with each and every patient. Charlie, thank you for being on the podcast, mate, and welcome. I know it's early over there in the States, and it's very kind of you that you're joining me at this time. So thank you.
Oh, you're welcome. Glad to be here.
Yeah. So as with all my guests, and especially with those that are from the USA, I'm quite interested, and sure the listeners are. Can you give us some of your backstory, about your early influences and then what ultimately led you to osteopathy? What made you become an osteopath?
Well, the Red River Gorge in central Kentucky was the thing that got me into medicine. When I was in college, there was a group of us that went to go rappelling. Abseiling, I think is what you call it there. Mm-hmm. And when we rolled up onto the site, this rather hysterical young woman came to us and kind of screamed, "Are you guys the rescue crew?" And our group wound up pulling a guy that had fallen 80 feet from the mountaintop, and we pulled him out. And I decided at that point that I wouldn't know nothing about medicine anymore, and so I enrolled in EMT, emergency medical technician training, and then went on to paramedic training, and then ultimately wound up in medical school. So That's what got me into medicine. Now, at the time, I knew nothing about osteopathy. And when I was applying to medical school, I met a guy who was a retired cardiothoracic transplant surgeon at Michigan State. And Michigan State University has both an MD and a DO school.
Correct.
And he said, "Have you heard about osteopathy?" And I said, "What's that?" And he described his version of it to me. And I said, "Well, I think that's probably the way that I want to go." And so that's what led me to apply to osteopathic school and eventually get in Pikeville. And it's been wonderful to be an osteopath since then.
And how old were you when that happened, Charlie?
When what happened? Getting into school?
Well, yeah, starting medical school.
Or the
EMT, when you were
20.
20, right. And so before that, you were obviously
probably 20.
20. Before that, you were in high school, and then obviously growing up. Where did you grow up? Where were you raised in the States?
Louisville, Kentucky, home of the Kentucky Derby.
Right. And your background and your parents, what did they do? What your mum and dad, what did they do?
Mom was a kindergarten teacher and then worked in the banking industry, and Dad worked as a factory worker.
And so, was there any inclination of little Charlie ever becoming something to do in medicine, or was that something out of left field?
No. Apparently, I am the highest educated person in my family lineage.
Right. And so, you had brothers and sisters?
Got a brother, yes.
Okay. And was he older than you?
Younger.
Younger. And okay. So you were obviously a trailblazer in terms of education for your family. I mean, what were your high school days like? What were your high school years like?
I was in the advanced program, so at that time it was kind of just in its infancy, where they were taking the people who were smarter, basically, and trying to tailor a educational program to meet their needs. I wound up graduating and was the first class to do this with college or university credit as you graduated high school.
Okay, and I mean, when you graduated high school, what did you do then? I mean, did you just go to work? Did you go and study something? What happened to you after graduating high school?
Went to college.
And what did you do in college?
Went in engineering. Had the worst professor of my entire educational career in calculus. Didn't know how bad this person was until she left on maternity leave with 2 weeks left to go in the semester. And we got the other professor who made calculus easy. But at that point, I'd failed calculus, which was a 4 credit hour course, and it was the kiss of death. So I wound up with an associate's degree in electrical engineering and then a minor in theater, and I changed my major to biology pre-med, and so I graduated with the BA degree in biology.
Yeah, right. And so, not long after that, you saved that poor fellow that had fallen 80 feet to down the cliff.
Yep.
Yeah, right. What was it like trying to get into an osteopathic school? I mean, was it easier because you'd done your EMT training? Was that how you were able to get into an osteopathic medical school?
I don't know. I look back on it, and the first question they asked me during my interview was, tell us about your outward bound sailing experience. And I thought to myself, if they're asking me that, I'm already in. So years later, one of the deans brought me aside, and she said, we've had 2,000 or so people at the time send letters in, and I just want you to know that yours have been hands down the best out of those 2,000. So I don't know if it's my letters of recommendation. I'm assuming that's what got me into medical school. Okay.
Because, I mean, our particular stories have a very similar timeline. I started my osteopathic training in 1999. I finished in 2003 and began practicing in 2003. And I guess... just hearing your story, you would have been a young man. Did you have any idea what you were getting yourself into when you decided to take up? I mean, obviously you knew that you'd had this encounter with the gentleman that told you about it, and he told you about it through his own experience, and he was at, I think, Michigan State, you mentioned. But when you showed up to osteopathic school, I guess, after finishing your medical degree, did you have any idea of the kind of philosophical nature of it? Did you have an idea of the impact it was going to have on you as a person?
No clue.
No clue. So is that generally the experience of most, I guess, medical trainees when they go and do osteopathy? Is it something that just is out of left field for them, or do they know a bit about it?
In growing up, my family knew nothing about osteopathy. So when I'm sitting in, the first day in orientation, all of it for me is new. I had no idea what was going on. And within the first 2 weeks, I knew exactly that that's where I needed to be, and everything I'd done in my life up till then had prepared me for being an osteopath.
And what hooked you? You said in the first 2 weeks, I kind of figured it. You figured out that's what I wanted to do. What was it specifically that you remember? What hooked you in those first 2 weeks?
Oh, we did muscle energy on the second cervical vertebra, and it changed under my hands. And I thought, you can't make that up. It's not some people telling you that, hey, this works and it doesn't work. It worked for me in real time, and I was hooked at that point.
And by that time, you already had some medical training under your belt. Is that correct?
No. This was 2 weeks into. So for us,
Right.
Osteopathic school is both medical school and osteopathic school together.
Okay. And so 2 weeks into it, you're bright-eyed, you're new, you're fresh. You moved the C2 cervical vertebrae. You felt it move under your fingers, under your hands. You palpated it, and it was amazing. And that was the experience that actually hooked you, and you said, "I need more of this."
Yep.
When did you start getting into, I guess, the philosophical nature of what you were doing and the rationale behind it, rather than just moving a joint? Because some other professions or therapies could also say that we move joints also. What I guess makes osteopaths unique is maybe their thought process. When did you start understanding that rationale a little bit deeper? In what point of your education did that start to happen?
I think for me, again, because of who I learned under, it was week one.
Right. Okay. And who were you learning under that was so influential? Like who are the people that really influenced your time at university?
Ed Stiles.
Right. Okay. And this was at Pikeville.
So Stiles was in the. Yeah, it was a Pikeville.
Go ahead. Tell us about Ed Stiles.
So Ed was in the first muscle energy tutorial given by Fred Mitchell Sr.
Right.
And Ed was, out of the 6 people that were in it, Ed was the only one who went back and spent time with Fred Sr. and really got into his head to learn how he problem solved. And then he took all of that experience because Fred died in the early 70s. Ed brought all of that experience to us and started teaching us from week one how to think, how to problem solve, like Fred Sr. had taught him.
Okay. That must have been an experience for you. Were there any other? I guess, muscle energy technique is one aspect of osteopathic manipulative medicine as it's known over there in the States. The other modalities obviously would have been taught. Were there any other, I guess, influential people in that program that you remember?
Ed pretty much was the program. There was one other person helping him, but it was Ed's thought process surrounding who he had learned from, and he's unique in all the profession at having his mentors. He's the only one that had those mentors. And so he learned from Perrin Wilson, he learned high velocity from him, he learned muscle energy from Fred Sr., and he learned cranial and functional from George Laughlin.
Okay. And I guess then moving on from your particular experience with education, which I think ended in 2007, what was the next step for you, Charlie? What happened after that?
So after graduation?
Yes.
Graduated on a Friday, started practice on Monday.
Okay, and straight into private practice on your own with a mentor. How does it work? To give us an insight, how does it work over there in the States? Do you go into private practice with another person that's already in private practice, or do you just go out and open on your own and off you go?
So either one is an option here. I went in under someone else who already had a practice established. And worked with that person for about 1.5 years, and then went out on my own, and I've been on my own ever since.
What was that experience like for a year and a half? Tell us about that. Like, did you learn under this person? Were they a good mentor? Were you able to bounce things off them and kind of, those first few years in private practice? I mean, you've obviously figured out that your education really starts once you graduate. And so what were those years like?
Well, I didn't get much mentoring that worked for me. Our practice styles were very, very different. So I was pretty much on my own learning. And thanks to my great educational background, was able to put that together really quickly. And I mean, we worked together until I realized that financially it was in my best interest to go out on my own.
So why did you choose to go with that practice if you had kind of thought that your treatment styles weren't a good match? What was the choice? What was the reasoning behind that?
I had some guaranteed patients to begin with.
Okay, so you just did it purely for the patients.
Yep.
Just to get your hands on people. Yeah. Okay. All right. So going to private practice, give us an insight on what the process is like over in the States in terms of, do you just open your doors? You start a business? Do you start a company? How does it work? Do you need some kind of licensing, some registration? What happens?
So you'll graduate school, go through your residency training, and during your residency training, you'll wind up getting your license with whatever state you're working in. Mm-hmm. Then you'll need a license in any state you choose to practice. That gets you the ability to work with patients. Then you have to go through, in order to open a business, you get with the Secretary of State, fill out some paperwork, open your business, pay your fees, and then you may have to ask for city permission to do something, but basically you rent a space and hang a shingle.
Okay. And is that still the same system over there where you're basically licensed to work in one state only? Like, are there cross-state recognition over in America? Do they recognize your registration amongst different states?
You need a license to work in any state that you actually see patients in.
Okay.
Now, one exam at the beginning allows you to get a license in any state, but you fill out the paperwork, you get your license, you pay your fees to maintain it, and you're good.
Okay, so it's not like you've got to go through an exam every time you want a new license.
No, one exam at the beginning that covers you forever, and then you get what's called reciprocity between the states.
That's great. Okay. Tell us about those early years out on your own in terms of not just practicing, but also trying to have a flourishing business, I guess. There's the practical practice side of it, then there's the business side of it. How did you handle that dynamic?
Well, the business side of it I'm still learning because they don't teach you that anywhere in our educational process. Yeah. The practice side was easy. Patients show up and you treat what's in front of you. And again, because I was very well trained in my educational experience, I felt like that part was easy.
Okay, and in terms of practicing, what were the main modalities of practice that you chose to use in your early practice? I mean, you would have actually developed as a practitioner over the years. I'm sure you would have done some further education and gone on and did some extra training. How were you practicing when you first started?
So functional, cranial, muscle energy, counter strain, Chapman's reflexes. That basically was the beginning. Okay,
and had you done any further training in any of those areas, or were you just did you continue on doing further training in those areas, or were you just practicing and utilizing your skill set and kind of applying that?
Further training, yes, but it was mostly what I was taught in school gave me a really good foundation for starting practice. And then I
Yeah.
took more courses, and as I would take courses, I would incorporate the things that I learned.
Okay. Tell us about the idea of the osteopathic hospital over in America. I know that I don't think they exist anymore, do they, Charlie?
There are still a few. There are not many, but there are still a few.
Right. Okay. Did you have any experience in those? Was that something that you aspired to, or is that something that just was beyond your reach at the time?
Where I trained was an osteopathic hospital.
Okay. Tell us about that. Give us an insight into how that ran and what that would be like, I guess from an osteopath's perspective, maybe from an MD's perspective, and then also what would be the perspective of the patient.
So the osteopathic hospitals came about because in the 30s, 40s, and 50s, if you were an osteopath, you couldn't practice in the MD hospitals. So the osteopathic doctors typically got together and they would buy a large house or a building and convert it into a hospital where they would see their patients. I was in a hospital that was formed in the 70s, and the doctors owned the hospital. It was absolutely a fabulous place to learn because it was small. We had an emergency room, we had intensive care unit, we had surgery, and so we would treat medical patients. There was a psych ward, and patients would come in. From their standpoint, they were going to a hospital. It just happened to be the one that was close to home. From our standpoint, obviously our philosophy was a little different, but by the time I had got to the hospital, they weren't doing much in the way of manipulation. They said when I came into the emergency room, I had done more manipulation in my first 3 days than had been done in the entire hospital in the last 3 years.
Wow. Okay. Was that something that was welcomed?
Yes, they loved it.
Okay. So let me then ask you, I guess from that experience, can you comment on what the differences would be between an osteopathic hospital versus just a orthodox hospital, I guess, and a traditional hospital? Say I came into the emergency room with a suspected fractured ankle. How would I be treated differently at an osteopathic hospital? What would be the main differences presenting in that space?
I would say nowadays, with the way things have changed, if they had an osteopathic manipulation service, at some point you would be evaluated and potentially treated. That's going to be your main difference.
How would that be different, though? I know I would be treated, but I mean, with the
treated osteopathically, hands-on
right.
treatment.
Okay, so in a traditional hospital, they would make sure that I wasn't going to die, that I didn't have a fracture. They would rule out making sure that I didn't have a fracture, and then they would apply the rest ice compression elevation protocol, and then maybe just send me on my way home with a pair of crutches. Whereas in an osteopathic hospital, instead of applying that protocol, would they just start applying treatment, maybe a bit of traction, a bit of articulation, looking at different tissues, different anatomy, looking at the knee, looking at the hip, and then they'll say, okay, we've given you that, you're fine to go on your way home. Would that summarize it, or is there anything I've missed out on?
They would probably have someone who was a specialist in manipulation come by and check on you, and then apply osteopathic manipulative treatment.
Okay. In terms of direct manipulation to the joints?
Or tissues, whatever that person was skilled in.
Yeah, okay. All right. And would that continue on for, like, would the patient be expected to stay there and continue on, or would they be discharged?
Probably discharged and brought back for outpatient treatment.
Great. Okay. All right. Well, it's a shame that they're slowly becoming a thing of the past. That's not good. What's the reason behind that, Charlie? Why do you think the osteopathic hospitals are not a used model anymore?
They're not economically viable in today's world.
Yeah. Okay. Do you think there's a way to make them economically viable? Has someone tried?
No. My own personal thought is medicine's going to have to collapse before it can be rebuilt.
Okay. Well, we'll get into that a bit later. I think that's a good area of discussion. Right. So I was doing some research on some of the courses that you teach, and one of the things that kind of triggered my intrigue was a course that you had up there, and it talked about Dr. Still's approach to foot and ankle injuries. Can you outline, I guess, what are some of the main the main headings of that approach in terms of how Dr. Still might view foot and ankle injuries, especially in light of his osteopathic thought process?
All right, so this course came about because of Rue Ticker. Rue is a podiatrist who is 98 at the moment, living in Napa, California. And Rue was the student and protege of John Martin Hiss. Hiss was a student at the American School of Osteopathy between 1911 and 1914. Sometime between 1914 and 1917, when he still died, Hiss fell off a horse and sprained his ankle, and nobody where he was at could fix it. So he came back, spent time on Still's front porch, where they sat down and figured out how foot and ankle injuries happen, and then how to treat them. Hiss went on to open the largest foot and ankle clinic in the world in Los Angeles on Wilshire Boulevard. He had 5 different clinics, 15 doctors, and they saw 600 to 800 patients per day doing just feet and ankle treatments. Rue saw Hiss when Hiss was in his 70s and Rue was in his 20s. And Hiss had 2 children, both of which became doctors, neither of which wanted to take over the family business. So Rue made a deal with Hiss and Hiss said, look, if you come in and work for me for 5 years, you can have everything. So Rue went on to learn from Hiss, and Rue's not an osteopath. He is a podiatrist. So his brain doesn't work like I'm always looking to take things apart, figure out how to make them better. Rue learned by rote and still does things exactly the way that Hiss did them, which is exactly the way that Still taught him to do. So it's a very short direct lineage. Rue and I have been teaching together for 10 years, and I'm basically taking the baton from him. So teaching how Still taught Hiss, Hiss taught Rue, and Rue taught me.
So tell us about some of the approaches that are taken with foot and ankle injuries from a treatment perspective. Tell us about some. Before you tell us about some of the treatment approaches, I guess can you walk us through some of the main diagnostic approaches from an osteopathic standpoint?
So the thought process is that you have 3 kinds of ankle sprain. One where you fracture the lateral malleolus, one where you fracture the medial malleolus, or one where there's no fracture. And where there's no fracture, the cuboid is the bone that causes the whole chain of events that leads to the sprain. The cuboid will medially rotate, that then drags the third cuneiform with it, so it will laterally rotate. When both of those move, they cause the lateral aspect of the talus to lose its support, and the talus collapses, dragging the fibula caudal and causing the ankle sprain. When the fibula moves caudal, the interosseous membrane separates, which is the only way that the mortise and tendon joint can move without a fracture. And so the treatment is aimed at putting all of those things back together in a stepwise fashion.
Okay, so I guess having the lineage there and especially working with Rue, how do you think that Dr. Still and I guess Hiss were able to come to these conclusions?
I'm assuming they felt it in their own body and then worked out how it happened.
Right. And how accurate do you think they have been? Like, how accurate do you think they've been? I mean, what's been the practical applications there in terms of Hiss doing that, having that particular approach, and then Rue obviously having that particular approach. Has there been any modifications over the years?
None from Rue that I know. Now, I had fall off a ladder 30 plus years ago, and ankle problems since then. Obviously, I'd been treated going through my training, and anybody that I could find with knowledge about the foot had treated me. I've had injections, you name it. I've tried to fix my ankle. Rue did more in 3 minutes than 15 years of treatment combined.
Yeah, wow. What's been, I guess, his take and then in extension your take on the implications of the foot and ankle in lower limb and lumbar spine injuries? Has that been something you've looked at?
Oh, it's huge. It's absolutely huge. Yes, the way that I was taught to examine the body, foot and ankle injuries show up in a very specific place. And I would say I find it in 30 or 40% of my patients.
Right. And Rue obviously being a podiatrist, is that correct? You mentioned he's a podiatrist?
Yes. Uh-huh.
So has he looked at that particular, I guess, chain or pattern of dysfunction? Does he kind of just look at the foot and the ankle and that's it? Does he recognize the implications that it has in, up the chain?
His license only allowed him to touch from the knee down.
Okay.
So did he, oh yes, he would say, some people I'd treat their feet and their headaches would go away. But he could not go and do anything to their head, upper body, just because of his licensure limitation.
But I mean, he would be able to treat the foot and then obviously assess what's happened higher up in the lumbar spine or the hips.
Nope.
I mean, no, he couldn't assess either.
Treat the everything from the knee down.
Everything from the knee down. Could he observe changes in the lumbar spine?
He could observe them, but he couldn't palpate them.
No, but I mean, if somebody had lower back pain and was saying he was speaking to them and they came in with a foot injury, he could ask them,
Yes.
Have you had lower back pain? Yes, I have had lower back pain. Have you had any incontinence with that lower back pain? Yes, I have, strangely enough. And then apply the treatment and all of a sudden the lower back pain disappears. That was a phenomena that he would have observed over and over again?
I don't know about over and over again, but yes, he's observed it.
Right. And so in terms of his particular practice, what are his thoughts on, I guess, maybe, I don't know if it's modern or if it's something that's been around for a while, but, podiatric practices like bracing and orthotics and devices in that way. What's his take on, and maybe by extension, give us your take on how you view that in light of the foot and ankle, and then also the lower spine, the lumbar spine and lower limb injuries.
Hello everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
Rue was a big proponent of shoe inserts, and orthotics. He had some that he would make on his own and some that he would have made. Because of when he practiced, he was all about leather. So carbon fiber, for example, isn't something that would have existed when he was practicing. He practiced for 55 years, and I think he stopped in 2010 or something like that. Again, big into orthotics. Bracing, he hasn't mentioned a lot of it. I haven't asked. My personal take on reading Hiss's book, and Hiss wrote basically 3 books, one called New Feet for Old, and that was more of a layman's book, and then one called Functional Foot Disorders. One version of it was, oh goodness, over 500 pages because it had a lot more x-ray pictures. Another version of it with fewer pictures was about 300 pages. In that book, Hiss suggests that the foot is a self-supporting structure. So my take on it is, if as osteopaths we get the foot working correctly, then an orthotic is like a plaster that you put on to help heal the tissue. And once the tissue is healed, you don't need it anymore. Unless you have injury that hasn't been addressed in a way that was necessary when it could heal, and now that injury is permanent, in which case you might need an orthotic permanently to help with that injury.
I mean, something as simple as an arthritic change, would that be something that may require, say, more of a permanent orthotic device?
Yes. I would typically do injections on that arthritic joint and see if we can restore motion and function. And if the function comes back and there's no pain and there's normal motion, then you don't need an orthotic.
Yeah. And I guess then in light of that, were there any ever uses of orthotics more so to affect anatomy higher up in the chain, or is it mainly just to address the problems in the foot?
For me, I make my orthotics out of heavy-duty file folders, so that they're cheap, easy, and I'll actually use them to adjust teeth and to adjust bones of the cranium. And so I use orthotics, or the concept of orthotics, for a number of things.
Right, but orthotics, you're talking about foot orthotics, right? That go into
Correct.
it. Right.
Foot orthotics, yes, to change the dentition, to change the cranium, sometimes to change the vision.
Right. And I guess, what's your thought process when you're trying to do that? When you're trying to affect something, say, in the temporomandibular joint, whether it's a dental issue or a cranial issue, what is your thought process when you go to put an orthotic device into the shoe? How are you thinking that's... Tell us about the chain of events that's going to happen where you're going to get a reaction in that cranium.
So the first thing for me is having an accurate diagnosis. What I typically do with my folks is they come in for this, they would lay down, eyes closed, teeth apart, palpate the body, notice any strains that you feel through the cranium in the tissue. Then have them open their eyes. Anything that changed would be visual in origin. Close your eyes again, bring your teeth together. Anything that changes there would be dental in origin. Then do both, open eyes, bring teeth together to see how they kind of correspond. And then you stand the patient up, and anything that changes there would be either proprioceptive or postural in origin. If they had those proprioceptive or postural changes, that's where I would bring in the orthotics and use those to neutralize, bring the patient back to neutral.
Right, so would you go directly to orthotics there, or if there's a proprioceptive or postural change, would you assess the entire chain? I mean, there might be a hip issue or some kind of lumbar spine issue or a pelvic issue. Why is it that you go directly to the feet?
It depends on their story, because from my experience, again, kind of the way that I was taught, if I've treated the rest of them, there isn't much left over to do. So in this case, I would have treated them before I would have laid them down, and I'm looking at these chronic changes that potentially from an accident that could have been many years ago. And sometimes these very small changes of 0.5 millimeter in proprioception can help the body to unwind over a relatively short period of time.
Yeah, right. It's the interesting concepts to discuss with you. And so my understanding is then when you put an orthotic in to footwear, it's going to affect, I guess, the proprioceptive feedback from the feet up into the brain via the neural pathways. But it's also going to have a mechanical effect on the chain. Would you agree with that, Charlie?
Yes.
Okay, so that mechanical effect, by you trying to affect something up in the cranium, the orthotic has to affect the entire chain mechanically before it gets to the cranium. How do you make sure that you don't affect something poorly?
I palpate the whole body before I'm done, make sure it moves.
Right. Okay. And are you going to, what about, I mean, the way that orthotics work, I guess, is when you put them in, they work over time. The changes happen quite slowly. Usually, from my experience, you need at least 4 to 6 weeks of wearing those before you can really start to see changes into the body. You get some changes happening straight away, but the really concrete stuff is happening usually a month to 8 weeks into it. Are you constantly reviewing and what you're doing there and making sure you bring the patient back and making
Absolutely.
sure you're seeing the changes that are going on?
Yep.
Yeah.
And again, because what I'm doing with my orthotics is kind of ultra precise, I think I see changes faster than that. 2 weeks, 4 weeks. And then the orthotics change, they might come out, they certainly would get modified.
Yeah, okay. Interesting, very interesting stuff. They're concepts that I guess are a little bit, I understand what you're saying and kind of can follow along with it. I do some similar work myself, but my philosophy is more around addressing the foot for the foot's sake, and then treating the rest of the chain physically myself, and allowing the orthotics to work their way through kind of unhindered. But I try not to have, say, a posterior innominate in mind when I'm making an orthotic. It's more about the actual foot, and then obviously letting the innominate regulate towards that as best as it sees fit. Letting the self-regulation happen organically. I want to ask you about, I guess, your particular development into cranial osteopathy or osteopathy in the cranial field. Tell us how you got into that space. Where did you do the bulk of your learning, and what made you move in that direction?
So we had to have basically 20 hours of cranial for graduation. And so we learned the sutural approach that Ed learned from George Laughlin while I was in school. And then I took a course through Hugh Milne's Institute, Visionary Cranial Sacral Work. I took the very first one. And its focus was kind of relying on more of your perception than your left brain, which was really enlightening for me. Then went and did a rotation with Viola Fryman before she passed away. And 3 days into my rotation, she says, we're starting a cranial course today, and since you're with me, I guess you'll have to take it for free. So, thank God for Viola. So I did my first 40-hour cranial course with Viola, and then did another cranial course while I was in internship and then started teaching with the Cranial Academy, and became senior faculty with the Cranial Academy.
Okay. And then, I mean, as you're doing this, you're applying it in your own private practice, is that correct?
Sure.
Yeah. And I guess what makes you move, I don't want to say away from, but what makes you move closer towards, say, practicing cranially versus practicing more structurally?
I think for me, it's what gets the result. That's the reality for me. What I tell my patients is, hey, look, if waving feathers gets you better, I'm going to wave feathers.
Mm-hmm.
But I'm looking for a consistently repeatable result with a good outcome.
And do you still use more direct techniques where you find it necessary, or do you find that you can get the results that you want to get out of with all your patients just through indirect methods?
I would say it's mostly indirect, probably 95% or so. When it comes to the foot, I find direct methods tend to work better, and I think it's because of the forces that we put into our feet.
Right.
When it comes to the head, what I recognize is we don't teach the full gamut of cranial. We teach Sutherland's second version and not the first version, and we don't go into, for example, Burl Arbuckle's version of how the cranium works. We don't cover dentistry pretty much at all. And so my experience, my clinical experience has taught me that the patients need more than what we're taught. And so I've gone down those rabbit holes, either learned from other people or taught myself. And so cranial for me is both a mixture of direct and indirect, and you do what works to get the changes to happen.
Yeah. Have you had any experience? I did a what's called a structural cranial course with Lisa DeStefano, who came out from the States. Have you come across her work, and what are your thoughts on that?
I have. Her work differs quite significantly from what Styles learned from George Laughlin.
Mm-hmm.
So
She mentioned that.
Yep. And I would say we don't see eye to eye on things.
Okay. Nothing wrong with that.
Yep.
It's good to have a competition of ideas. Did you ever come across anything by Philip Greenman? I mean, that over at Michigan, you said that one of the first people that got you, or that spoke to you about osteopathy was from Michigan State University. Had you come across,
Yes.
or did you think about going out there and doing work with Philip?
I met Phil, spent a weekend with him when I was a student. He and Ed were friends for 40 years, and Ed's the one that got Phil into cranial.
Yeah. Well, we still use. I mean, Philip Greenman's book. That green book that everybody talks about is like that's a staple in our education. And it probably, I mean, was that a staple in your education too when you learned about technique? Did you guys refer to that text, or not really? No.
And
Okay.
I think it's because I'm going to go back to Ed spending time with Fred Sr.
Yeah.
Ed had a different understanding of how the body worked, and I would say a more fine, precise understanding than Phil did.
Can you expand on that? So why do you find that Ed had a better understanding of the work than what, say, Philip Greenman may have?
So when they took that first tutorial, Ed was the only one who came in having spent time with Laughlin and had functional experience. So he had indirect experience. Everybody else in the class had only direct experience. And so they were seeing it through the direct lens. Ed was seeing it through both. And he got a different understanding of the first course. And then when he taught with Mitchell, he further refined it. So Greenman talks about the sacral axes. In none of the pictures that I've seen in Greenman's book is he ever focused on a sacral axis. And I think it's just because Phil didn't have the experience. So when Ed taught us about how to find the axes, and then in my clinical experience, we've gotten so ultra precise in finding the axes, and that makes a very huge difference in your application of the treatment. That when I look at Greenman's book, I'm like, oh my God, it's nothing against Phil. He was a wonderful guy, and he had great things to teach, but he didn't understand how precision makes the difference between, let's say, a treatment that you have to really work at and one that is super duper easy.
Yeah, okay. All right, well, that's a fair enough explanation. All right, well, what have been some of the challenges that you, I guess, I mean, now that you seem like you're doing a lot more teaching, would that be correct, Charlie?
You know, pre-COVID, I was doing a lot more teaching. COVID hit and the world went to hell in a handbasket, and
Yeah.
I'm doing some, but nothing like I was before COVID.
And your teaching is mainly face-to-face education, is that correct?
Yes.
So you're not doing as much teaching now, but what has been some of the, I mean, COVID obviously presented challenges, but what are some of the challenges that you faced going from, I guess, a practitioner to an educator?
Oh, I don't know that there were challenges, because to me, I'm using principles the whole time. So, like most people teach technique, we weren't taught technique. We were taught the principles behind the technique, and applying the principles created the technique. So for me, that's my teaching. Here are the principles. Let's apply it to this person in front of us.
And how did you find the uptake of that teaching? Like, you know, were people just going, yep, you know, like, did they know about you? Are they interested in what you have to say? Who were your main clientele, Charlie? Like, who were you trying to teach?
Well, and until the war started, I was teaching in Ukraine nearly every year. I've taught in New Zealand. I've taught in Canada, all over the U.S., in England. Goodness gracious, I'd have to go through that.
And I guess how were you able to? I mean, I'm assuming that, you know, he's Charlie Beck, and he's got his practice. And does someone just knock on your door and say, "We'd love to learn what you have to teach"? How did you get yourself out there as an educator?
Usually, it was meeting someone at a conference.
And so you're regularly attending conferences and doing
Yes.
that?
Yep.
Right. Okay. And what's been your experience out here in Australia? Have you come out here and taught some things out this way?
A little bit. Goodness gracious, probably 10 or 11 years ago, but nothing super formal. It was just a small group gathering, almost like a study group.
Okay. And you told me previously that you're licensed to work in New Zealand. Is that correct?
Yes.
Have you worked there before?
Yes.
It's, I guess, very similar to the system we have here in Australia. What have you found to be the differences in working in New Zealand versus working in the States?
Goodness, I'm limited as to what I do in New Zealand because it's a different license than a medical license.
Yes.
It's been wonderful because it's made me think. I have to, I can't inject this, so what am I going to do? I can't do an image on this particular thing, so how am I going to get the same information? That's taught me an amazing amount. But what I've noticed is my training has made me, I would say, unique when I come to New Zealand because nobody else has had the same training. So I'm finding things that other people weren't trained to find.
Can you be specific in that in terms of your training? What is it that's been different about your training, osteopathically speaking?
Again, this was Fred Mitchell Sr.'s approach to how the body works and what I was trained by from Styles.
Okay. And so it's from a manual medicine perspective, though, like the hands-on approach. Did you find that not having the pharmacological application there available to you, you said that made you a much more, resilient osteopathic manipulator? Would that be correct?
Yeah. Yep.
Yeah. And yet the education that you received under Ed made you a little bit more aware of some of the things that maybe the local osteopaths weren't aware of.
Correct.
Okay. How long did you spend studying? Oh, sorry, not studying. How long did you spend working in New Zealand?
Oh, collectively, it's probably been 5 months over the course of 20 years.
Wow. Okay. Is it something that you do regularly? Do you go back there and just do a few weeks and then come back to the States?
Or a few days, yeah.
Or a few days. What's the connection to New Zealand, Charlie?
I have a really good friend that I met at a conference 20 plus years ago who lives in New Zealand and is an osteopath. And he said, "Oh, hey, if you ever want to come out, just let me know and I'll put you up." And so I want to say it was the next year we arranged to go and visit, and we've had a connection since then. And like I said, we're really good friends.
Yeah, great. What's the osteopath's name? Maybe we can get him on the show.
Paul Hume.
Paul Hume. All right. Well, shout out to Paul. Paul, if you're listening, let's connect and we'll get you on the show, and you can tell us about some funny stories about Charlie staying in New Zealand. Charlie, when you, I guess, were working in New Zealand, what was your, I guess, critique of the, other than obviously them not being aware of some of the things that you were maybe aware of due to your training, what would be your critique of, the type of osteopathy that you saw being practiced in New Zealand?
Very visceral oriented, which isn't a problem. I do visceral. But how do I put it? Not as mechanical. And if it's mechanical, you have to be able to pop it, not necessarily release it indirectly.
Yeah. Okay. And why did you think that was a problem that the profession faced? Like, why do you see that as an issue for the osteopaths there?
When I see patients that have been seen by other practitioners and there are, I would say, consistently obvious things that are missed, that are not addressed, then I see that as a deficit somewhere in the training.
And that's obviously you're talking about mechanical issues that are being missed.
Yeah, mechanical issues.
Yeah, okay. To what degree do you attribute, I guess, your medical training, your osteopathic medical training, to you being able to, I guess, treat the way you treat now, in a sense that, I mean, you were taught in a way and by people that had some direct lineage and experience. My guess is that if you were to go to other tertiary institutions that are teaching osteopathic medicine, they probably wouldn't have the amount of direct manual medicine that you would have been exposed to. Would that be a fair assessment in terms of your particular background in education versus someone that might be training these days?
I think so, yes.
Yeah?
The training here at least seems to be going downhill.
What do you think what would be the antidote to that? Has the profession figured out a way to improve that, or is that a sinking ship?
I'm pretty sure the ship is under the waves at the moment.
Yeah. So tell us what's going on then in American osteopathy. What's the future? Where's the future headed? Is it? I don't know much about it, and I think some of the listeners might be interested because, I mean, that's the birthplace of osteopathy for me anyway, and I guess we're obviously educated in the history of osteopathy. That doesn't need to be rehashed, but we're obviously interested in osteopathy staying alive and well in America. What's happening over there? What's happening with the profession? Is it in a good place? Can it be better? Tell us your view on things, Charlie.
Well, when I graduated in 2004, there were 35 osteopathic schools by that time, and I think there were 35. Anyway, they were putting out about 3,500 graduates per year. and there were 35 slots for residency for doing neuromusculoskeletal medicine. So basically for specializing in osteopathic manipulation.
Okay.
So we call that 1% of the graduates. Now there are 7,000 graduates, 55 schools with another 15 in the hopper, and 23 residency slots. This past year, there were 8 applicants, I think, and one of them dropped out. So 7 people out of 7,000
Wow.
that are going to specialize in osteopathic manipulation.
It doesn't seem like you have a problem with the volume of students that are applying to become osteopaths. You have a problem with the people that are wanting to learn osteopathic manipulative medicine. Why do you think that is?
I don't think our profession, I would say the legislators in our profession or the administrators believe in osteopathy. There are schools that want to make osteopathic manipulation extra. You don't have to take it to graduate.
Right. Why do you? I mean, what's happened there? Why is it in such a bad state that the administrators and the people who are in charge? And when we talk about that, who are we really talking about over there in America? We're talking about the American Academy of Osteopathy. Are we talking about who are we talking about? I mean, I know when you talk about the professional association here in Australia is Osteopathy Australia. You know, that's the body that represents osteopaths. But then we have a regulatory body that represents the public. But the real people who, I guess, can affect change on a professional level is the association that represents osteopaths. So are you talking about the fact that the association that represents the majority of osteopaths in America, you feel that the people there don't particularly believe that osteopathic manipulative medicine is something that needs to be done to become an osteopath?
I'm going to say, first of all, I'm giving you speculation, and I don't know much because I try to stay out of the politics of it.
Yeah.
But we have the American Osteopathic Association, who represents all of the graduates in every specialty.
Okay.
And then we have the American Academy of Osteopathy, who represents the folks who do manipulation. The American Academy still seems to be behind manipulation. Mm-hmm. The American Osteopathic Association doesn't seem to be.
Okay.
And because they represent the entirety, let's say that there are 2,000 people doing manipulation and there are 100,000 people in the AOA, we're a very small subset. So, and what it seems like over the years is it's easier just to make us go away. Okay.
So, I guess if I was talking to somebody who is not practicing OMT, osteopathic manipulative medicine, what is it that they would say defines them as an osteopath if they're not practicing in that way?
Maybe it's the philosophy, maybe it's the fact that they went to osteopathic school, I don't know.
Right, okay. So what do you think osteopathy is, Charlie? I asked all the people on the podcast what their view is about the definition of osteopathy and what an osteopath does. So tell us what you think, Charlie. What is an osteopath and what does an osteopath do? What defines osteopathy?
Goodness, for me it's hands-on medicine first. Mm-hmm. And that belief system that the body can heal itself if you help it along. And only if it can't, then do you reach into your bag for anything else, whether it be homeopathy, acupuncture, or pharmaceuticals. Mm-hmm. So that's my take.
So do you believe that osteopathy can only be practiced, not can only be, but do you think that a hands-on version of osteopathy is really the only way that you can practice osteopathy?
You know, I'm looking for a reference for this, but at some point I believe still said, if you're not doing manipulation, I'm going to come take my degree back from you.
I don't disagree with him. I'm just thinking that, I mean, you know, if that's what osteopathy is, then it really puts a bit of a roadblock on our thought process, because then, I mean, you know, if you're a myotherapist, or if you're a chiropractor, or if you're a somebody who treats, you know, ART practitioners, for example, they could argue that they're hands-on practitioners, and we use our hands, and we help people heal with our hands. So why can we claim to be osteopaths and they can't? Why can we claim to be doing something special that they can't do?
I would say, at least in my experience, it's because they all get taught a subset of the whole.
Okay, so, and when you say that, are you talking specifically about manual technique, or are you talking about something else?
It would have to include the manual approach plus the philosophy. So a myofascial therapist, for example, isn't going to get bony articulation. They aren't going to get disease processes. And so ART practitioner, same thing. You get a subset of the whole. It's not to say your subset isn't powerful, but it is a subset.
Yeah, I agree with you there. But in terms of applying treatment, why is it that, say, an osteopath applying a myofascial release would be a better? Why can we argue that an osteopath applying a myofascial release can achieve a better result than a myotherapist applying a myofascial release?
Different assessment, I would say.
Different assessment. Okay. And where does that come from? Where does our assessment, I guess, ideas come from?
It's the osteopathic thought process.
So does that then define the difference between what we do and what other people do?
I don't know if it defines everything. It's big in the definition.
Yeah. So could you have a conversation with somebody, Charlie, and advise them on an aspect of their health osteopathically?
Sure.
So then,
I feel like I do it all the time.
Yeah, I'm sure you do. I do it all the time. People call you up and they say, "Hey, I've got a swollen ankle. What do I do?" And you can give them some advice, and that advice will probably be different than what a physical therapist might give them. And so that really, I think, shows that what we do hands-on is a massive part of it, but I think it can't just be restricted to our hands-on. It has to be thought about in the way that we think and the way that we approach things, and we can communicate that. Our ideas are different, and I guess my question to you about osteopathy was trying to understand how you thought about it, and if it was more about the idea of what to do rather than actually what to do. So yeah, I'm really intrigued, especially that you're on the other side of the world, and we can have this conversation. It's a very intriguing thing to me. So moving on, I want to now ask you. We talked about your approaches to cranial. Cranial being, I guess, a technique that requires a subtle palpatory skill. Would you agree with that, Charlie? No. You don't think that
you can take somebody who's got bricks for hands and teach them cranial.
Oh, you can teach them cranial, but I guess the movement of tissue that you're feeling is a little bit different than what you would feel, say, in a swollen tissue that might have just had a tear. You can put your hands on something that's torn and feel that it's hot and swollen, whereas trying to feel the cranial rhythm might be a little bit more challenging. Would that be an assessment, or is that not been your experience?
So I would say if you're going to do this traditional Sutherland approach, you're correct. But if you do more of a mechanical approach to stuck sutures, for example, it's not that much different than anywhere else in the body.
Yeah, cool. Okay. if I was a young practitioner, a new graduate, and I'm very impressed with what you're doing, Charlie, and I want to learn from you and try to do what you do and try to achieve the similar results that you're getting. But I've just graduated and I want to be able to, I guess, do what an experienced practitioner is doing. What's your advice to those people? What should they expect in their first couple of years of trying to do that? And then what should they be trying to do to achieve that goal?
It's a thought process first. My first thought is you need to make sure that you have defined your dominant eye and dominant hand and understand how to use those to remove the bias that your body may be giving you in the assessment process. Then you need to understand how to blend with tissue. Once you do those two things, the things that they taught you in school start to make sense. And you start to get consistent results. The biggest thing I notice in, I think, most of our educational process is that we don't teach students to get results that give them consistency in their practice. Because even if you're consistently bad, I can help you. I can look at you and understand what you're doing wrong, and I can help you get better results, which builds confidence. If you're inconsistently getting results, it's hard to correct. And then it does a number on your psyche because you think that, oh, osteopathy doesn't work for me. That leads you to want to do something else. And I think that's the thing I would correct with people. It isn't, from what I've seen, it's not what we teach that is, I would say, wrong. It's that we teach it incompletely to guarantee confidence.
Okay. And then also, what would be some of the more practical advice that you could give them in terms of, practicing, how many patients should they be trying to get their hands on, should they be expecting, what time frame would they be expecting to start to, get the results and get that consistency in their practice?
Last patient of the day, because if you go over with them, you're not impacting anybody else. Last patient of the day is the time to try out new things. It's the time to hone your skills. How long until you get good results? A month? I mean, it shouldn't take long, again, if we're teaching correctly. This isn't something that you have to stay at it for 30 years before you get good. You'll get better in 30 years, but there's no reason you can't be good the first month out of school.
Yeah. Tell us about your particular practice, Charlie. Like, what does a day in your life look like in terms of your clinical life? How many patients are you seeing? How long are you seeing them for? Tell us about your clinical life. Are you you got a admin team there? You work on your own? You got other people working with you? Tell us about your experience.
So new patients are an hour, follow-ups are a half an hour. I work 3 days a week, have basically kind of secretary and me.
Right.
That's basically
now,
it.
What are osteopaths charging over in the States? What's the going rate there to see an osteopath?
A whole lot more than you guys charge.
Probably. The dollar doesn't help us too.
It ranges from new patient visits $200 to $800 for the first hour.
Yeah.
And then follow-ups range from $115 to about $325.
Okay.
From the people that I know of.
Yeah. And okay, so then I guess that begs the question: Is osteopathy accessible to everybody or most people in that population there where you're at?
I feel like, seeing the people that come to me, yes. But it requires that you get results. So, for example, if you were charging $500 a visit and you weren't getting results, in my mind, you aren't going to stay in business very long.
Yeah, no,
But
that's,
if you charge $500 a visit, and it takes 2 visits to clear up whatever's going on with you, you're going to have a successful practice.
Yeah, look, it's just, I've worked in clinics that are based in fairly, I guess, affluent areas of Sydney, and I've worked in clinics that are based in areas that weren't so affluent. And I guess I found that some people were priced out of osteopathy, and it's usually the people that are, I guess, most in need are the ones that are priced out of it. Like, to give you an example, I remember seeing a patient when I was a younger practitioner who complained that her shoulder was sore because the maid didn't turn up and clean her home for her, so she had to vacuum. She had to get the, clean her floors on her own, and that hurt her shoulder. Fair enough, but then you go out into other parts of Sydney and you get to see the mum with 4 kids, and carrying shopping bags and trying to, make sure the baby, carrying the baby on one arm and 2 kids hanging off her other shoulder, and then she's got the housework to do and the cooking to do, and then having to go outside and do some kind of emergency because something's happened, and then they come in with some kind of trauma because they've fallen over and they've landed on their sacrum, and those people are quite desperate to see you. They've actually got real problems. They've got real injuries, and yet they were a little bit priced out of the market. Do you think that that's something that does that play on your mind? I guess when you go to treat people, do you ever feel like that there are people that can't get access to your services because of pricing, or is that something that you just don't give much thought to, which is okay?
Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the 2 best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show.
Yes, I have given it thought, and these are the same people who, they say they can't afford you, and yet they pull up in a $100,000 car.
Yeah, I'm not talking about those people.
If you need to see me, and you're willing to fork up the money to pay for that first visit, we'll work with you. Sometimes we give you a discount. Sometimes I see people for free. Yeah. But ultimately, for me, it's you have to honor me enough to want to be able to pay my rates.
Yeah, understandable. Yeah.
That's it. And then I'll honor you. And if you come in and say, hey, I'm doing this, but I can't afford to eat for the next month, you're probably going to get a free treatment.
Yeah, good answer. What have you found? I mean, you've obviously come across, you've trained with and come across some fairly astute practitioners and successful people in the osteopathic world. Have you found any common personality traits amongst the successful ones?
Confidence, I think.
Okay.
I think that's it. Because people use different treatment approaches.
Yeah.
But it's the confidence that seems to set them apart as being successful.
Okay. Right. How much do you pay, I guess, or how much do you put emphasis on the communication style rather than the actual treatment style? Like, your ability to communicate, your ability to get your message across, the ability to have the patient buy into what you're trying to do with them. How important is that in the treatment process versus just your manual therapy skills alone?
Well, I remember spending time with Herb Miller before he passed, and crotchety old Herb is what everybody would call him.
Okay.
And Herb would come in and say hello, and he would put his hands on you and begin treatment and never speak a word about your treatment. He might ask you how your kids were doing. He might keep his mouth shut, and people would come out and say to me as a student when I was with him, I have no idea what he does, but I feel better when I leave. And I thought to myself, that's never going to be me. I want people to know. Whether they understand or not is different. But I'm not going to stop talking. I'm going to teach them about their body. And so it's a different approach. I mean, the people that keep their mouth shut, if they're good, folks are still going to come back and see you. If you can sell them on what you're doing because you explain something, hey, this is about to move, and then they feel it move, now they've got their buy-in. And in my experience, they tell everybody. They may still say, I don't know what he does, but he told me all about it, and I feel better.
Yeah, that creates a buzz, and it gets you a lot more referrals. Charlie, from I guess maybe your limited experience about what you know about Australian osteopathy, which is not far off what you probably would have experienced in New Zealand osteopathy. I guess the major challenge for us here, we're obviously different. We're not MDs. We don't have really a it's not like we're called allied health practitioners here, and we're meant to be allied with the general practitioners who are MDs, but yet I think there is a much closer relationship between MDs and physical what's known as physiotherapists here in Australia. You would call them physical therapists. There's a very, very close alliance, and part of that close alliance, I feel, comes from I think it's a different approach that is more aligned philosophically. The medical doctors will basically look at physiotherapists as people who can do take the very non-invasive measures, non-manipulative measures, I guess, if you want to call them that, and try to get the patient better that way. And they would always, I guess, liaise with the GP, and a lot of the times patients will go back to the medical practitioner, obviously seeking pharmacological treatment because the physical therapy wasn't successful. That seems to be a model that sits well with the medical establishment for whatever reason, and that could be a good thing or a bad thing. Everybody can make their own decision on that. Where I think osteopaths have struggled is to get the respect and the exposure to the medical profession, and I guess have our skills and our results recognised. Being, I guess, the hybrid of both, yourself, an MD as well as an osteopath, what recommendations and what advice could you give to, I guess, the wider profession here in terms of, just advancing in Australia and making sure that we continue to grow as a profession and yet not lose that osteopathic mindset, that osteopathic touch? Is there anything that you can talk to that about?
Well, again, my understanding is that as a worldwide profession, we are moving toward evidence-based osteopathy. And there's a problem with that. And I'm blanking on the person who said this. It was one of the folks that Ed studied from. He said, if you take 100 folks with low back pain and you apply a protocol to them, which is what basically we would do to make something evidence-based. The problem is that you have 100 people with a minimum of 100 different stories about how their back pain occurred. And a protocol approach probably isn't going to work for a big chunk of them. And that what we do in osteopathy, or what we should be doing, is an N of 1 is significant for us. We're doing the same thing, so it's my understanding that you guys no longer teach cranial because it's not evidence-based.
I don't think cranial, I don't think it's a massive part of any university programs in Australia. I could be wrong,
Yep.
but I don't think it is anymore.
And muscle energy is on its way out? Not evidence-based?
No. Muscle energy is still in, from what I understand, at all 3 institutions. So is HVLA.
Okay.
Yeah.
And so what happens there is, if you are a practitioner who happens to know something that you learned on a visit to a foreign country that you learned from a shaman, doesn't matter what it is, you do it, you apply it in osteopathy, and it helps the patient. If it helps the patient and it helps more than one, it's repeatable for you. It's your skill. But we wouldn't teach that in osteopathy. So now what we're doing is because we're trying to keep up with the MDs, we're limiting the tools that we can use, and basically playing right into what I would consider a trap that we've set for ourselves. I have to be able to use the MD tools osteopathically to get osteopathic results. That doesn't work.
Yeah. And so would you, I guess, if you were the King Sultan of all osteopathy in the world, Charlie, how would you go about, I guess, addressing those two paradigms together? The need to, I guess, have some kind of evidence base versus the need to maintain osteopathic principles and rationale? Or can't they both exist together?
I don't see how they can peacefully coexist together.
Yeah.
I'm thinking kind of full-on French Revolution kind of thing.
Okay. What would happen hypothetically in this revolution, Charlie?
I think what happened for us is that the week after Still died, the profession said we want to be as good as the MDs. And there's nothing wrong with that, but what they should have said is... As good as the MDs in what sense, though? Well, that's what we've been trying to prove. We've been trying to make ourselves MDs. And what should have been said is, we want to be DOs, good in our own right, and different than the MDs. It would have taken us down a different path.
Why do you think this doesn't seem like a uniquely American experience? Because we have I think we have the same problem here. I think there are many people that are studying osteopathy these days because they couldn't get into medical school, right?
Right.
And that's not ideal. And there are many people who, are studying osteopathy and then go on and then end up doing their physiotherapy extension or masters or whatever you want to call it. And so why is it, this, like I said, this doesn't seem like a purely American phenomena. What is it about the the doctor, let's call it the doctor, for lack of a better word, whether you're an osteopath or whether you're some kind of other recognized healer, what is it about that person that wants to be an MD, that is pushing towards, I need to have this recognition?
It's the standard. I mean, it's like if you have breast cancer, mammography is the standard. Mammography causes breast cancer in some patients.
Yeah.
Yet it's still the standard.
But yet what you practice is better than the standard. And so it's like you've got this little bunch of gold in your hand and you don't even know that you have it. And then you're trying to actually search for something that's less valuable.
Yep. I noticed in osteopathy early on in my career, we wanted to teach you everything. If you're a student, please come and spend time with me and let me teach you. And then you get a little experience and, hey, I'll teach you a little more. And then the moment you get good everybody's climbing on your back trying to keep you from excelling and making them look bad.
Yeah. Yeah, it's a strange phenomena, because it's like you're trying to be something that you feel like is the standard, but yet you're already something that's a bit of, I'm not trying to create some kind of we're better than you are kind of scenario, but it's a standard. The standard that osteopaths have set historically has been very high, and they've been able to achieve very, very good results with their results on par, if not better than what if you would take it per capita, the amount of patients that we see versus the amount of patients they see, who ultimately improves, we're if not on par, if not probably at a better rate than what traditional medical practitioners would be at. And so it's an intriguing thing to think about. I haven't really been able to put my finger on it, and I've met people who have wanted to become medical practitioners, but they then did osteopathy and have said, wow, it's amazing that it's amazing that I ever wanted to do the other thing in the first place. And I've met the people that have been the other way around, where they still crave the attention and the validity of being a general practitioner, which is intriguing to me. It's strange, but it's intriguing. It reminds me that there's a very famous Seinfeld episode where George Costanza's trying to win a girl over, and she's dating this other bloke, and his name's Neil, and he figures out that Neil just does something a little bit different than he does, and then Jerry finally shakes him and he says, "You've out-Neiled Neil. You've got the girl." And so he's focused on getting the girl, on meeting the bloke. He's focused on meeting the guy that is doing a better job than what he thinks is doing a better job, when he's already doing the best job he could do. So it was a funny one, and that reminds me of what I guess some osteopaths are trying to achieve. But it's intriguing how that is something that it's across the professions in all different countries. And you talked about also the movement towards evidence-based model. It looks like that's a tsunami that we're going to get taken up in. I just hope that we can. I hope that we can withstand that particular onslaught. Our particular experience here, I don't know if you had a similar experience over in the States, but we had an experience here during COVID where we were actually designated as essential businesses. So we weren't. A lot of other businesses were forced to close their doors. We weren't forced to. We were actually asked quite openly by the regulator here to maintain practice and to stay open, because they said that we were essential to the health system. And I saw that as a really good recognition, because I think when there's some kind of I guess back then what they thought was going to be a pandemic, when there's something like that happening, people's true colours come out, and the medical establishment actually came to us and said, you need to stay with us, And so if they didn't think that we had something to offer, they probably wouldn't have done that. And so I guess the message out there is to just stick true to your osteopathic principles and your philosophy, and try to apply that as best as you can, and then teach that to somebody else before you die, so that it can live on. Charlie, I'll leave you with the final thoughts before we say goodnight.
I like what you said.
Yeah.
Yeah.
Thank you. Just give us some final thoughts on, I guess, what you'd like to see being taught in the future to osteopaths. Like, what would you, rather than just technique, what would you like to have, I guess, passed down into the future generations?
Well, certainly a principle-based approach, because if you're using principles, the principles never fail, even though the technique that you choose might. But the thing is that, still said, if you aren't getting the results that you think you should be getting, you don't know your anatomy well enough. And I think although we teach anatomy, we teach dead anatomy. We don't teach alive anatomy. We don't teach how things go together, how the body functions as a whole, how the eyes impact the whole body, how the teeth impact the whole body, how the ears impact the whole body, and how all of that stuff changes how you appear in three-dimensional space when it's not right.
Those principles that you talked about, and making sure that you practice according to your principles, and not just having a technique-based, practice. And you said earlier that the principles actually bring about the technique. They are the things that formulate the technique. Can you give us some idea on how to take those principles of osteopathy? You know, that the body is a unit of body, mind and spirit, that there's a structure and function relationship there, and that the body has its own regulatory mechanism that brings us to homeostasis. Can you maybe give us, in your final thoughts, some idea on how to take those principles and actually practically make them come to life within a treatment? Like, what are the things what does a practitioner have to do to make sure that those ideas, those concepts, those principles aren't just ideas in the sky that are floating around, but actually bring them down and make them effective in the treatment room?
So for me, that would be, how do I approach a patient when they walk in the door? So let's go through that. Subconsciously, when they walk into my treatment room, or I walk in and they're already there, I'm asking mind, body, or spirit, which is the biggest thing they need today. So, for example, if I am happy and I walk into the patient room and all of a sudden I get sad, that isn't about me. That's the patient showing up through me. And then I need to ask some questions to figure out what that's all about, because that's really why they're there. I may be putting my hands on them, but that's secondary to what they really need. If that didn't happen and they come in and they say, I remember a patient that I saw in New Zealand, and I looked over her history and it said two visits ago, fell down the stairs, hit right side of head. Then next visit, hit right side of head on fire escape. This visit, she came in and said, I hit the right side of my head again. And in my mind, I went, this is a pattern. Okay, I've just met you. The right side of the head in Chinese medicine is the masculine energy. Is there a guy in your life that you're banging your head against? And instant tears. I'm like, okay, that's why you're here. You're here because your body's giving you a message and you needed somebody to reflect that to you. So we did a treatment to fix the problem with the head. But I said, look, you have a thing that you can do. You can either do nothing and your body's going to keep turning up the volume, or you can do something. And the something is, you can either reframe how you think about the relationship, or you can exit the relationship. Those are your options. And I said, look, I'm not invested in the outcome, so whatever you choose is up to you. And she came back a week later, beaming, and said, I left the relationship. And it's exactly what I needed. So for me, those are like emotion and belief system. And then if it's body, it's about getting precise, accurate, and consistent with your diagnosis and your treatment. And that takes reflection after the treatments, and then enough treatments for you to be able to learn where you are making errors and then how to correct them.
Yeah, great. Okay, well, I guess for everybody listening, what Charlie's telling us too is that those principles really live within his practice, and they're not just ideas that are floating around. They really make an impact to his practice and also the lives of his patients. Charlie, I want to thank you for doing this over there, from over there in the States. It's morning over there, so good morning to you. So thank you for doing that. For everyone else, that'll be the end of the episode. Charlie's staying along with me. But for everybody, thank you for listening. Thank you, Charlie, and I will catch you on the next episode.